a 59 years old male. His chief complaint is found colon polyp for 2 months. The colonoscopy shows a 2 times 3 centimeter nodular protruded lesion at the rectum. The biopsy pathology shows low-grade villous tubular adenoma. Our diagnosis is rectum lateral spreading tumor. The treatment plan is ESD. Yeah. This is a colonoscopy picture.
Yeah, so this is the first case. So we could.
You hear me, Prof. Lee? You hear me? Dr. Tumbari?
His mic is not connected.
Dr. Tumbari with us?
أنا سامعك يا دكتور أحمد.
هو قال ان هو دلوقتي احنا هيعمل اي اس دي، وقال الباثولوجي بتاع الماس دي ايه؟
اوكي. his voice
انت انا ما سمعناش في الحقيقه.
دكتور لي
هو عنده مشكله.
Do you hear us, Dr. Lee? Your voice is not clear. We don't hear your voice.
شغله من لحظه وفصله تاني. لما يلعب هنا اهو يبقى المشكله من عندنا احنا. شوف الراجل فين؟ مين يا باشا؟ قصده على السنه، قصده على السنه. من عنده يا باشا، مش من عندنا احنا. الصوت ده من عنده يا باشا، مش من عندنا احنا. موصول من عنده. هو
Dr. Lee, we still don't hear your voice. Could you please check voice connections, please?
Prof. Lee?
Is that okay?
Yeah, we hear you now.
Yeah. Oh, okay. Yeah.
Okay.
Yeah. So that's
Can,
one
can,
problem. So I often hear my voice very clear. So it will with however that's the connection.
okay.
就是我老听着我自己的声音。
Can you explain to us, please, what is the procedure you will do?
So 你看我老听我自己的声音，你把我自己的声音给我切掉。我现在我这个麦克里面，我老听着自己的声音。So that's another problem. So you could hear me, but I just hear my own voice from my iPhone. 我先说吧，我先把这个摘掉。你们先调着啊，你拿那个帮我调着。So this is the first case of our presentation today. So the patient in the very beginning is left-sided. You know, so we just use water jet to just determine which position for the patients. Here we could observe the relation here from the 12 o'clock to 4 o'clock, but the border of the relation is not very clear. So, but in the center of the relation, we could find blood noodle. So, according to the white line endoscopy, it's kind of mixed nodular type LST, lateral spreading tumor. So here we use today the endoscope is a gastroscope. It comes from the sonoscope. So the type of the EG550L. We have the transparent cap, at the tip of the endoscope to help us, to show the lesion so much clearer. So we have the, the function of the SFI. It's a spectrum alteration technique to show the lesion much clearer. So here's the border of the lesion. So another function we call the WIST, the versatile imaging staining technology to show the microsurface or the macrofacial is much clearer. Here's the border of the lesion. When compared with the white line endoscopy, the border is much clearer. When we turn back to the white line endoscopy, we use the endocarmine staining. Where the suction, just to remove the residue of the spreading dining. Here's the lesion. Under, so after endocarmine staining, the border gets much clearer. So I think with the white line endoscopy, the border is not very clear. So just before, it's a resection of the lesion. So generally, we didn't give any kind of marking for the colorectal lesion. But this time, I want to give the marking before resection of the lesion because the border is not very clear. Only after endocarmine staining, we could, show the border, which is very well. This is the border of the lesion. And this is the border. 标记。Well, there's a electrosurgical unit with the early, 200D with the effect of 3. It's an interval of 4. For the knife we use today, it's a dual knife, come from the Olympus. Uh, 不是，普通的牛。好，40就可以了。Okay, so marking the border of the lesion. So the patients get general anesthesia. Even after sleeping, the body is not very clear. 你给我修修我那个耳机好了，你就给我啊。So the next question is how to remove the lesion. So today we want to perform ESD because the size of the lesion is nearly 4 centimeters large, and also it's a mixed nodular type of LST. So chances of the fibrosis, so it's very high. So we want have the in-block resection of the lesion. So just after marking of the lesion, we use submucous injection to lift the lesion to help us resect it. So what we often use is the function of the gravity to remove the lesion. Here, the lesion is the top of the gravity, and here's the water. So the right side lateral position for the patient is very suitable for ESD at this moment. So for the index agent we used today is sodium hyaluronate. So inject, please. Okay. 不收。Injection. 可以。Injection. 打。好。打。哎，没打。打。好。打。好。打。好。再打一点。打。好。OK， 保留。We have the submucous injection half circumferentially. So next, is sequential resection, incision. We use a dual knife to have the sequential incision. 你麦克修好了吗？
麦克风可以了吗？老师？
好了，但是他们不让我工作，看不见。
bleeding, we use a coagulation to stop the bleeding. 收回来。可以了，知道。The large vessel here, coagulation.
So another injection. 对了是吧？
Hi, Dr. Lee.
Say yes.
Now we will, after doing the cutting, what was the next step?
It's not very clear. Could you say a bit louder?
It was a submucosa and submucosa. Then,
Yes.
Then
Yes.
what we will do?
So submucosal injection again and dissection.
Okay.
Yes.
Prof. Lee,
Yes.
is this maneuver preceded by EUS or something like that to be sure that the tumor is not extended to the deeper layer?
Yes. So we just so that's before ESD. So we just with help us show us how deep the lesion invade into submucosa with the wide endoscopy. We have the nearly 80% with accuracy rate, but with with magnified endoscopy we have more than 90% of accuracy. But with EUS maybe near only 70 to 80%. I don't think EUS will help us much. That depends. Is how deep the submucosal invasion. So under dissection again. Cool. 今天就做这一个了。哎，中间没有切开吗？不是，咱们这个边不是已经切好，咱们就切在这儿，是吧？ with half the water jet, we could show us, our working plane very clear. This is a muscular layer, so we should be so much careful, try our best to avoid an injury.我可能要需要牵起来，我再看一看哈。再给我打一个。牙线帮我备一个那个圈儿，记在小手指上，先帮我备着。So another injection. So elevation here is not very good. Sometimes for the mixed nodular type lateral spreading tumor, so sebarosis, sometimes high, it's sometimes very severe. So we have another injection to just elevate this part. It's much better.
Good morning, Dr. Lee.
Yeah, morning.
What about these vessels? Are you going to coagulate them?
Yes, for a large vessel, we use a co-grasper. But a small vessel just like this, we use the knife, the tip of the knife, to tapenate the vessel and coagulate.
Do you like to have anything to help you in retracting the fragment, like clips or anything?
Yes, we have prepared. We have sometimes used the clip wrench method to help the elevate the lesion. We have prepared, but at this moment, I'll try, the common method once more. Okay, we have prepared, the ring at this moment. Do you knife, please? 一会儿先要刀。出来。好。So for the vessel like this, it's with a dual knife. Coagulation is okay.
Excellent job.
Yes, thank you. This is a muscle layer. This is a difficult part. After finish this part, I think it makes much better. This is a water jet. And many small vessels. So it's the reason why we use coagulation. There's a larger vessel here. Coagulation.
Dr. Lee,
Yes.
sometimes we see versions of this procedure. Sometimes they do tunnel, sometimes they cut around. Which is better?
Yes.
Sometimes, yes.
Yeah, for the large lesion, maybe have some branchial incision at first, then finish the left. For the small lesion, it's totally subbranchial incision is okay, because half the branchial incision will help us, to store more, submucosal inductor agent in the submucosal layer, help us just make it ESD procedure faster.
Looks very easy in your hands.
Yeah, thank you. Maybe it's next this part. 来，给我那个注射。So because we have the gastroscope, so the retroflex position is much easier than compare with the colonoscope. So what's next? We just cut this part. So maybe this is okay. So
Dr. Lee.
Yes.
Have you faced any invasion during dissection, accidentally discovered during doing the procedure? And if you faced this problem, do you continue or stop at this level?
What problem?
I mean, if you faced during dissection any invasion from the polyp or from the tumor, do you continue dissection and use clips or stop the procedure at that time?
So if it's very, very difficult, I just use clip rinse method. If it's also very difficult, we just perform EMR. So I think at first we should just finish the procedure. It's our own aim.
And leave it at the level of a certain level of dissection. Leave it the patient and refer to surgeon, or what you do?
Surgeon sometimes. If our preparation happens. If there's very severe bleeding, we can't control with the endoscope. We just with the help of the surgeon, but seldom. Low, low. So maybe it's a retroflex position. True. 打，不行，打，好。好像并没有那么容易，谁来帮我扶一下镜子？好。So the position of the scope is difficult. I will find my assistant to help me hold the endoscope. 好了，好，那个刀给我。是，马大夫来帮我扶吧。This is the marking of the lesion. So as for this part, I just have to pre-cut. And so we have prepared the ring at this moment. If needed, we will use the clip ring method to help lift the lesion. OK， 好，出来。哎呀，还是很难啊。So this is part of very difficult. 哎，我刚才去的是这边是吧？是去的另外一边。是去这边吗？不是去的这边，但我看不到这边。这边，我把跟上面连起来就可以啊。来，出道。好。是，正好在这个。哦，没切身吧？好了。要牵一下吗？牵一下会好一些。好，牵一下吧。这里面有一个结节。So next, we want to use the clip ring method. That's before we start. 还有你们要注射。That's before we start, with the clip ring method. We just want, have the lesion superficially resected. Then after that, we use the clip string method. 来帮扶镜子。好，出3，好，推镜子3，好，推镜子3，好，可以，倒给我，没问题。打完划完全周，然后线一拉，出，可以。下边是标记吧？往上走。这是那个边儿，可以了。然后就是可以了，全周了。好，对，给我拿那个线，那个夹子把一个牙线，我是要一个小手指头那么粗的牙线，就要一个圈，不要线。 先别，你先不用加，让我给我看一下，拿过来啊。So this is the ring we have made. So this large. We have the the clip here. It's open place, close, open, close. It's come from the microinvasive. So open place, yeah, close, yes. This is the ring we have made. It's a moment ago. Okay, it's a turn in the direction of the 10 o'clock. 再转一点点，好，张开。Open place. It's close. Oh, sorry. 张开。加住。Yeah, close. So we have another clip. 再要一个。So the next step is very important. So direction of the line is very important. So sometimes we see we have the just inside of the rectum. Here it's not very good. In the beginning, so the elevation is very good, but after we several minutes, the elevations got much worse and worse. So where we want to put another clip, it's just in the anal side. 有点长，关上，有点长这个圈儿，是，所以这个圈儿太长了，这不是小手指头，这都张，加，没掉吧？打住。So I think this direction is much better. So injection again. 注射，对。出。打。帮扶镜子。So injection, please. More. Okay. 再往近一点。So injection, please. Okay. 再往近。Injection. Okay. Dual knife. 好处。So here's again another vessel. We also use coagulation. Another vessel here. So be careful with muscle layer. Another vessel here. The muscle layer. There's a ridge here. Uh-huh. It's a muscle layer. It's maybe more injection. Too short. We have a very small part left.咱们还是关闭一下，把你那个大夹子帮我拿过来，沃克的大夹子。不用不用，你们一会儿给我备着。 往扶一下镜子。打，OK 了，倒给我。近一点，稍微近一点，出来了。可以了。出。
Dr. Lee.
Yes.
What is the average time to finish completely this procedure?
This picture, I think, is 30 minutes.
30 minutes?
Yes. Yeah, it's finished. 要一个义务钱。
A very good job, Dr. Lee.
Yes, thank you.
Very, very nice, clear, no bleeding, easy. It's like a magic, Dr. Lee.
Yeah, thank you. So I think for the next step, just close the defect. To remove the specimen and fix the specimen is by my assistant. 不，义务钱把它取出来。不，对。你给我营业钱吧。So we use co-grasper just to calculate the exposed vessel. 好 so we use a soft calculation with the effect of 6. No, 关着。这样，压住。可以了。If you use a foreign body forceps, just remove, the specimen because there's a clip, attached to the specimen. 这样。给我那个夹子，插到镜子。So wipe the endoscope. So there's still no conclusion. Is that we need to just close the defect after we finish the whole procedure of the ESD. But for the installation less than 2 centimeters, so if they close the defect, the chances that post-procedure bleeding it gets much better compared to no clipping. So this time we use the clip that comes from the Boston Scientific. So because without resistance, the endoscopes themselves could just turn the clip freely. It's no reflection. So this time we just from the lower part of the defect to close the defect. Okay. Remove the air a little bit more and to another part of the defect. Yeah. Yes. One. Close. Another one. Maybe this from the upper part is much better. Okay. So turn the direction of the clip from the anal side of the defect to the oral side. Oh, not so easy. Maybe it's this part.
Dr. Lee, do you usually close the defect with the clips, or special for this lesion?
Yes, sometimes.
What is the indication for closing the defect? Is it
so
bleeding?
For the larger size of the defect, sometimes we just close it. That's reduce the chances of post-procedure bleeding. And also a concept of training. So if perforation happens, sometimes it's difficult to close the perforation. But with proper training, just close the defect as a hypas. If perforation happens, hypas to the close the perforation.加注，我看一下。张开。Yeah, failed this time. 国王这边转一转。好，张开。加注。可以吗？打住，打住，没有。好，再咬。这样，再转一转，转一转，好，回一点。打住，打，对吧？I think 1 or 2 somatic clip are needed.
Dr. Lee?
Yes.
Closing this defect may increase the incidence of pocket formation or collection of stool after that, making infection or abscess or like that? Or, yeah?
Does that any kind of research?
No, I just ask about that. Is that okay or not?
Is that okay?
Yeah. You change it into closed space or partially closed space.
Yes.
When it is opened, it decreases the incidence of collection and infection, I think. What's your opinion about that? Is
so
it okay, or you have another opinion?
Yeah, so for the post-procedure infection, I don't worry about that. What we worry about is first procedure perforation and bleeding. So if no was close, for the defect, the chances of the post-procedure bleeding is nearly 10%. If with a close defect, it's 1 to 2%. It's just much better for the post-procedure bleeding, also for the preparation.
Dr. Lee.
Professor
Yes.
Lee, for this excellent job. We will move now to the Sonoscape presentation, video presentation, and we will come back to you to see your lecture.
Yeah.
Okay.
Yeah, thank you.
Thank you, Professor Lee. Thank you.
Yeah, thank you. 可以了，转走了。这样，打住。好，很好。第二个不播了啊。第二个不播了，第二个然后讲课其实也没有，讲课5分钟就可以了，10分钟。我们有广话时段。是。现在切过去。好。会场播个宣传片，7分钟左右。那行。没事，我就把这个弄完。啊，很好，其实很好。你看一开始转播，然后有问题，我觉得也还好，咱们应对的还不错。他一直能听见您说。是这样。但是他那边Zoom掉线了，他没有及时把我们拉起来。是他其实这样是一直听不到我说，我能听到他们说话。就是后来换了那个之后的话呢，他就能听到我说话了。但是呢，我一说话的时候，通过传又回来，我这个老能听到我自己说话，老干扰。啊，所以呢，就是后来就把这个拿掉。反正一开始我也不用听他说，完了我就在那说，完了以后换上这个之后就好，觉得没问题了。这个病例呢选的也还特别合适，是因为它边界非常不清楚。
Control mana？
对，就是因为病灶呢不大不小，对吧？你要太小了也没意思，你要太大的话又费时间。那个换别的地方。
اوكي دكتور طنباري، دكتور احمد طنباري سامعنا؟
ايوه سامعك يا دكتور.
كنترول روم. We will move to Sonoscape video presentation now.
Yes,
Sonoscape
yes,
symposium.
we are moving to Sonoscape presentation, right?
Thank you. ممكن بس الصوت الكنترول روم شوف الصوت معانا مش سامعين هنا.
SFI seems to be very useful for advanced detection, specifically of very flat non-polypoid lesions in the luminal gastrointestinal tract. This mode seems to be very helpful for advanced characterization of the tissue, specifically to identify the lesion as non-neoplastic or neoplastic. And
by the time being, is the only gastroscope where any endoscopies are very familiar and they could do a U-turn very easy just by using the node. But my general impression about 550 from Sonoscape is very good because it's in the first approaches a very consistent system and have no we use it from 8 a.m. to 10 p.m. every day, and
I've used it for a multitude of procedures. I've tested your scope really well, and it held its own. It's a really durable scope.
It's been so quick and so fast in achieving incredible target. So I'm expecting in the next future to become one of the major company in the field of endoscopy.
SFI seems to be very useful for advanced detection, specifically of very flat non-polypoid lesions in the luminal gastrointestinal tract. This mode seems to be very helpful for advanced characterization of the tissue, specifically to identify the lesion as non-neoplastic or neoplastic. And
by the time being, is the only gastroscope where any endoscopies are very familiar and they could do a U-turn very easy just by using the node. But my general impression about 550 from Sonoscape is very good because it's in the first approaches a very consistent system and have no we use it from 8 a.m. to 10 p.m. every day, and
I've used it for a multitude of procedures. I've tested your scope really well, and it held its own. It's a really durable scope.
It has been so quick and so fast in achieving incredible target. So I'm expecting in the next future to become one of the major company in the field of endoscopy.
Thank you.
Yeah, hello?
Hello? Yeah.
Yeah.
Thank you. Thank you,
Yeah, could I start?
Yeah, I have the honor to introduce Professor Lee Binge. He's professor at Department of Gastroenterology, Beijing Friendship Hospital. Please, the floor is yours, Professor P. Lynch. Lynch B. Lee Binge, sorry.
Yeah, Dr. Lee. Yeah, it's good morning, ladies and gentlemen. It's a great pleasure to be here again to show my slides. It's not kind of, you know, how to say, it's just a summary of today's case. So just share is my slides.
Can you share your slides, please? Yeah.
Okay. Yes, is that okay?
Yeah, thank you very much. We have 15 minutes.
Yeah, could I start?
Yes, please.
The second case. So for the colorectal polyp, we have there is a nice classification. So the MBI International colorectal endoscopic classification. It's classified into type 1, and type 2A, type 2B, and type 3. For type 1, it's kind of a hyperplasia. Type 2A is low-grade adenoma. For type 2B, it's high-grade adenoma or intermucosa adenocarcinoma. For type 3, it's deep submucosa invasive carcinoma. Today, we show one case of colorectal lateral spreading tumor. So LST. LST refers to lateral growth of lesions at least 10 millimeter in diameter. This is in opposition to the traditional polypoid or flat or depressed lesions. For the LST, it's subdivided into granular type and non-granular type. For the granular type, we have the homogeneous type or nodular mixture type. Today, our case is a nodular mixture type. For the non-granular LST, it has divided into flat elevated NG-LST as well as pseudo-depressed type. Here's the picture. This one is a homogeneous granular type LST. This is a nodular mixed type LST, and this is a non-granular LST. This is a pseudo-depressed LST. So for the prevalence of endoscopic kudu LST subtypes, the homogeneous granular type LST takes more than 35%. The chances of submucosa invasion rate is 0.5%. So for the homogeneous granular type, the chances of the mucosal invasion is not very severe. So we could have the EMR even for the lesion larger than 2 centimeter. So for the flat elevated non-granular type IOST, it takes 33% of the total IOST. It has the submucosal invasion rate nearly 5%. For the nodal mixed granular type IOST, it has takes 26% of the total IOST. It has a mucosa invasion rate of 10.5%. The least part of IOST is a pseudo-depressed type. It takes only 5.5%, but it has a mucosa invasion rate is more than 30%. Also, the risk of the submucosal invasion is closely related with the size of the IOST. For the size of the 10 to 19 millimeter, the chances of submucosal invasion is 4.6%. When the size increased to 20 to 29 millimeter, the chances of the submucosal invasion is increased to 9.2%. For the lesions larger than 3 centimeter, the chances of submucosal invasion is 16.5%. And also different kinds of types of the IOST locates in different places of the colon. For the non-granular type IOST, it often locates in the colon, not the rectum. But for the nodular mixed type IOST, it often locates in the rectum. It's nearly 77% of the cases like this locates in the rectum. Also, for different type of IOST, we have different type of treatment or resection methods. For the homogeneous type IOST, we could use EMR as well as the EST. Why we could use EMR to resect lesion like this? Because the chances of submucosal invasion is very little. So we don't, demand, the lateral, lateral margin of the lesion. We don't worry about the cancer risk of lesion like this. For the mixed nodular type IOST, the cancer risk is 13%, and also non-granular flat inflated IOST, the cancer risk is more than 10%. And for the pseudo-depressed type IOST, the cancer risk is 28% to 70%. For the, the mixed nodular type, for the flat inflated type, or the pseudo-depressed type IOST, our treatment for lesion like this is an in-block resection. And also, we just pay attention to the nodular mixed type IOST as well as the pseudo-depressed IOST, because the chances of canceration and chances of the deep submucosal invasion is very high when compared with other parts of IOST. So today, the endoscope we use is come from the sonoscape. It has several different functions. That's the besides the white light endoscopy, they have the SFI. We call it spectrum focused imaging technique. It's a figure in the middle that's like this. It helps us find the lesion. That's like the polyp, find the early cancer in the colon. It's another, it's a spectrum alteration technique. It's a WIST. It's what we call is a versatile intelligent staining technology. With this technique, we could show the surface and the vessel much clearer when compared with white light endoscopy. And this is a white light endoscopy. This is SFI, and this is WIST. Looks like. Here's one case. Since there's a rectum, with a white light endoscopy, show the lesion like this, but the border of the lesion is not very clear. With ISFI, show the lesion is much clearer, and also the border is much clearer. With the width, we can show, the surface and the vessel much clearer when compared with the white light endoscopy. This is the last slide, just some summary of today's case and today's topic. So ST, sometimes the boundary of the lesion is not very clear. It's easy to miss, and also gives a great headache for the endoscopist to resect the lesion because the border is not very clear. So what we use a spectrum alteration technique or dye staining to highlight the lesion. So we should also pay attention to the high risk of coloration and SM invasion lesions, just like the size was more than 3 centimeter, or there is a noodle size more than 1 centimeter for the mixed nodular LST, and also for the mixed nodular LST and as a pseudo-depressed LST, the chances of coloration and the deep submucosal invasion is very high. For the treatment of the lesion, we have the EMR, EPMR, we have the ESG, also we have the surgery. For there's homogeneous granular type, LST, EMR or ESD are all okay. For the other type of LST, because the chances of the submucosal invasion, also the chances of the submucosal fibrosis is very high. So what treatment for this kind of lesion is ESD. Thank you for kind attention.
Thank you very much, Professor Lee.
Thank you, Professor Lee. We will go to...
Thank you, Professor Lee. Can I ask a question, please?
Yes.
Usually the differentiation between the types of the lateral spreading tumor is difficult, between the mixed granulon type and the granulon type and pseudo-depressed type. So usually it's difficult for us to differentiate. Can we do EMR in any lesion less than 2 centimeter in any type of them? Because you mentioned that you have to do ESCD in the mixed type. So can we do EMR in any one of them as long as its size is less than 2 centimeter?
Yeah, so it's a very good question. So this is indication of the ESD. For the lesion, the size more than 2 centimeter. So the ESD is, we prefer ESD. But for the lesion size less than 2 centimeter, sometimes, it's a scar or recurrence of the lesion. Even the size is smaller than 2 centimeter. So EMR is very difficult. So what we often use is also ESD to treat lesion like this. Sometimes for there's mixed nodular type LST or the non-granular type LST, fibrosis, in the submucosa very severe. So elevation sign is negative at this moment. So what we use is also ESD.
Thanks, Prof. Dr. Lee. We will go to the next session. Prof. Dr. Ayman Fuad, Prof. Dr. Ali Farrag, Prof. Dr. Muhammad Najib from Cairo University, and Dr. Asma Jamil from Mansoura University.
Yeah, thank you.
Thank you very much, Professor Lee.
可以听了。
eye seems to be very useful for advanced detection specifically of very flat non-polypoid lesions in the luminal gastrointestinal tract. This mode seems to be very helpful for advanced characterization of the tissue, specifically to identify the lesion as non-neoplastic or neoplastic. And
by the time is the only gastroscope where any endoscopies are very familiar and they could do a U-turn very easy just by using the node.
My general impression about 550 from Sonoscape is very good because it's, in the first approaches a very consistent system and have no we use it from 8 a.m. to 10 p.m. every day, and
I've used it for a multitude of procedures. I've tested your scope really well and it held its own. It's a really durable scope.
It has been so quick and so fast in achieving incredible target, so I'm expecting in the next future to become one of the major company in the field of endoscopy.
صباح الخير. صباح الخير. اولا احيي منصوره على اللقاء الجميل دون انهم خدوا انيشيتيف وسط الظروف اللي احنا فيها، واشكر الدكتور حازم حكيم على الدعوه الكريمه. ومعانا ممثل دكتوره اسماء من جامعه المنصوره، الدكتور محمد نجيب، وانا هنبقى تشير للجلسه الجايه. الجلسه الجايه هكون من ايطالي فروم ميلان، هيتكلم معانا فيها هيورينا لايف ديمو دكتور اليساندرو ريبيسي، وهو is the director of the digestive endoscopy unit at the Humanities Research Hospital ميلان. انا شايف البروشور انه هيتكلم على حاجه اسمها حبيب بروب. حبيب بروب ده من البروبس اللي بيتعمل بيها يعني coagulation للتيومرز، فهنشوف بقى بالظبط ايه اللي هيحصل النهارده. جهزوا نفسكم لان هو الحبيب بروب ده دلوقتي بقى من الحاجات المهمه جدا بالذات في البنكرياتيك تيومرز. يمكن الدكتور احمد معانا دلوقتي هو يعني ايه عنده خبره جيده بالموضوع ده.
Credo.
Good morning. Dr. Alessandro.
Hello.
Hello, are you ready?
Yeah, actually, two main things. You may not recognize me, but I'm not Alessandro Repici.
Okay.
I am his co-worker, Andrea Anderloni, that send you all the best from Italy. And second point, we were supposed to perform a procedure with the Habib radiofrequency ablation on a patient, but due to the COVID, the patient was stopped. So we do not have the opportunity to show you the case that we were planning, that actually was a recurrence after endoscopic ampulectomy in a patient of 84 years old that was not considered suitable for surgery. So the plan was to treat the recurrence, the intrabiliary recurrence of the ampuloma and to place a stent in. Unfortunately, the patient is now COVID, so we will book his procedure in the next month. Due to this fact, with Alessandro Repici yesterday, we discussed about the opportunity of showing you another interesting case, we suppose. So if it's okay for you, I will show you the case that we have ready just now.
To start with, we are sorry for what happened to your patient, and we are really eager to see what you are going to give to us, because now we have to expect what you are going to give to us.
That's very kind of you.
Thank
and
you.
I suppose that this is also a very interesting cases that will stimulate our discussion. We are facing here a 42 years old man that 4 years ago had a cholecystectomy done for biliary colics. Unfortunately, after cholecystectomy, he developed jaundice due to the complete stricture of the common bile duct. As you know, this is a complication, a possible complication of cholecystectomy. Despite we suggested to perform a rendezvous with percutaneous and endoscopic approach and subsequent dilatation and stent placement, the colleagues that were from another hospital decided to operate the patient because they were claiming that he's young, and so they want to do something that is complete. So they performed an anastomosis, biliary anastomosis. So the patient has now an altered anatomy with a biliary anastomosis, a bilioenteric anastomosis on Roux-en-Y. Again, unfortunately, 1 year later, so 2 years ago, the patient started developing recurrent cholangitis. He was a very fit man. He was working with his muscle, and month by month, he had to quit his job. He lost 10 kilos because of this sickness. He was sent to us to understand what's going on, and basically, we showed with a magnetic resonance that he had a stricture of the bilioenteric anastomosis. So we had to decide what to do with these patients, and we were thinking about different possibilities, but we decided 1 year ago to perform a gastroenteroanastomosis by placing a hot axios and to perform the ERCP through the hot axios. We were able to reach the biliary anastomosis. We were able to treat in a different session the stricture by dilation and placing plastic stents.
That's a very long story, and
yes,
and it's
very
very interesting to us.
Yes, because I think that it's very important to understand what's going on with such a disease. Those are benign diseases that can affect the life of a young guy more than other more serious diseases. So it's very important to know which are the options and to send the patient to the right place in the right moment.
So what are you going to do now?
The patient did well for 1 year. So a few months ago, we removed the stent by place it in the biliary tract, and we removed the hot axios. After 1 month, he started again having cholangitis. So we think that we still have to modulate the biliary anastomosis. So today we are going to face a particular case of recurrence after this kind of treatment. So we are going to have a look in the stomach to see if there is still the gastroenteroanastomosis in order to restore it, to place another axios over there, to dilate, and to enter to reach the biliary tract to see what's going on. So
Great.
If it's okay for you, I'm going to start. I'm working in an X-ray room with my team. This is Monique, the nurse, and this is Alessandra, our anesthesiologist, that is keeping the patient steady by propofol under spontaneous breath. I'm
Welcome
using...
for you. Welcome for them all.
Yeah, thank you. I'm using a gastroscope, a Fusion gastroscope, operative one, with a 3.8 operative channel. And this is very important. We will see why. So with CO2, I'm going down to the gastric body. I hope you can have the endoscopic view.
We have it clear.
Okay, so first of all, my first question is, do we still have the anastomotic tract available or not? Because this is the first question. So I remember I placed the hot axios nearby the pylorus. So I'm going down to check. I have some water pump here, because we need to see. This is the pylorus. Let me see. Little bit contract, but okay. And probably nearby here, you see here this little ulcer. Yes. I think this could be the area of my previous, I'm pretty sure about that actually, of my previous gastroenteroanastomosis. So by adding also the help of the X-ray that I hope you can see,
we see
I can see, you know, also the area of the metallic clips placed by surgeon that were placed right across the common bile duct, and this is why we are here. So assuming that this is the pylorus, as you can see, and this is the duodenal bulb, see that?
Yes.
Okay, this is very important to understand pretty well the anatomy. Okay, assuming this, I will take a look here.
We see some bile coming.
This is good. It means that hopefully the tract is still open.
Yes.
So by placing a catheter with a long 0.035 inch guide wire, I will try to find the way in order to understand. Ok, mandami avanti il filo guida. Do you have also X-ray evaluation? Okay, bravissimo. So first of all, I'm pretty happy with this. I think we have reached the other tract, the intestinal one. Okay, see that? Okay. I will put some contrast, please, Monique, to check. Bye. Do you see also X-ray?
Yes, we have it.
Okay. As you can see, I'm in a small bowel just now.
Will you give me just 1 minute to explain to the audience what are you doing?
Yes.
هو دلوقتي كان عيان دون قصته طويلة جدا. نهاية القصة انه عامل عملية ما ينفعش يوصله البيلياري سيستم عن طريق الاوبننج العادية. وهو عمل له بروسيجر وحط له ستنت بين البيلياري سيستم وبين الاستومك، وبعد كده انا بقى كويس شالها. بعد فترة حصل له اوبستراكشن تاني، فدخل دلوقتي بجايد واير خلال الفتحة اللي كان فاتحها زمان جوه البيلياري سيستم.
اوكي.
كان عمل كوليسيستكتومي وجاله بوست كوليسيستكتومي ستريكتشر، وبعدين عمل سيرجري تاني، عمل هيباتوكوجينوستومي، وبعدين جاله اوبستراكشن بعد الموضوع ده. يس. ستريكتشر تاني. نعم؟ ستريكتشر. شال انه بقى كويس. Okay, we are following you.
Okay, nice. I understand everything you have said, so I'm happy.
Okay.
So now we have done the first step. We still have, you know, the anastomotic tract, but this should be first dilated in order to reach the biliary tract. And then we need to keep it open for the subsequent repeated ERCP that we are going to do every 3 months in these patients, because we are going to treat him with multiple stenting.
Okay, just give me 1 minute again.
Yeah.
دلوقتي الفتحة اللي في الاستومك دي بينها وبين بين الهيباتوكوجينوستومي لوب، هيوسعها ويدخل بيها من المنظار ويشوف الاوبننج بتاعة الانستوموزيس فين ويحط فيها ستنت بعد ما يوسعها، ويقعد يعمل الكلام ده كل 3 اشهر. Okay, we are following you again.
Okay, so in order to restore the gastroenteric anastomosis, I am going to place an axiostent that, as you know, is a luminoposimeter stent that will allow us to pass and to withdraw the scope many times and will allow us to reach the biliary tract. For this purpose, I'm
do
going,
it now?
Yes, I'm going to use the hot axios
now?
20.
Okay, great.
The particular thing that we are going to do is that we are going to place the hot axios, not by the EUS guidance, but by a frontal view standard operative scope. So this is very particular because this device was born to be used during the interventional EUS, but it will allow us also to do this particular stuff. Okay. I don't know if you are familiar with the hot axios system.
Yes, yes.
I think so. So this is the handle. This is the catheter. The catheter is 10.8 French. So my scope is channel is 3.8 millimeters. So it will allow the stent to pass. Very important to, to wash the stent by water in order stent. So the beautiful thing of some devices like this one is that you do not have to change your practice in order to use the device. The device will adapt to you and not the opposite. This is very, very important to me. Okay.
نرحب بالدكتور أيمن معانا في التشير بيرسونز.
صباح الخير دكتور علي، صباح الخير عليكم جميعا.
صباح الخير. We need you to give us the steps of putting the stent.
Yes, this is a particular indication of such a stent. Actually, those are not the indication that are provided by the company.
Yes.
Those are clinical indication. I am the doctor. I am deciding to use this device in this way. So I'm going to put the stent basically like we do with other tubular stents. So guide wire, let me mention. The stent will arrive. See that?
Hello?
Yes.
May I ask a question?
Yeah.
When we use the hot axios stent in the EUS, we can see the other lumen that we are going to oppose the lumen to the lumen that I am coming from.
Yes.
Now you are not using an EUS, you are using a direct front view scope. So what is going to be the landmark for you to know the distal part where you are going to open the distal phalange before approximating the two lumens together and opening the proximal one?
This is a very important question. Thank you for raising the question.
Thank you.
Basically, since we are going to use this device as other tubular stents, we are going to use the X-ray image. As you can see now, I have the guide wire placed into the small bowel. You see, it's going towards the anastomotic biliary the bilioenteric anastomosis. You see the clips. So basically, I'm going to push the catheter of the stent on the guide wire very far, so that I'm sure that I am in the other tract, so in the small bowel. Can you see the X-ray just now?
Yes, we have it.
Okay, dammi tensione. The nurse is giving me tension and I am advancing the stent. See that?
Yes.
Ok, tensione, più tensione, di più, di più, di più. Tendi, 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 deve andare... Tendi, tendi, tira, 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 tira. Stai tirando? Ok, so, I need to go far away. So, I think I am inside the small bowel. Do you see?
Yes.
So the problem here is that I cannot fix the stent. So we need to pay more attention. I remove the yellow marker and I start releasing the first flange. Così. You see?
Yes.
Now, radiologically, you should see the stent that is going to open. See the first flange?
Yes, it started opening, I think.
Okay, the first flange is now opened. I can withdraw a little bit the scope, and I can adjust by radiologic image. See that? Now you see the black marker endoscopically. Can you see?
Yes.
So, radiologically and endoscopically, I can see everything. So, I release the second flange, hopefully, by endoscopic view. See that?
Yes, yes, it's opening nicely.
So you need to be very careful here because you are not fixed. So we need to do it
slowly,
like this. To pay a lot of attention in order to allow the stent to be open in the right position. Okay?
Okay.
So, yeah. Now we are going to place a CRA dilator, balloon dilator. See the small bowel over there already?
Yes. So far, so good.
Okay. You're right. Multiple step here, multiple step. Yes. So, if you can give me a CRA 15 to 18. Yes.
Could I ask a question, please?
Sorry?
You say, yes.
Correct.
You used the hot axis stent for untraditional indication. You said the two passed through the stent. Why didn't you use the uncovered metallic stent and go through with the spyglass or craniotomy?
Sorry, I didn't got your questions.
You said you used the hot axis stent to pass through the stent. Yes.
Yes.
Why didn't you use the uncovered metallic stent and go with the craniotomy or spyglass?
Oh, this is another interesting question. I did this for many reasons. First of all, if I go with the spyglass, I won't have the possibility to do interventional. I need to place multiple plastic stents in order to dilate the anastomosis, in order to keep the biliary tract open. And so I need to have an operative scope, such as a gastroscope or a duodenoscope. So I need large diameter.
Yes.
Second, if I place an uncovered stent, this is a benign condition, so I want to be able, later on, after 1 year, to remove everything. If I put an uncovered stent, I will have a lot of ingrow and overgrow. Third, the hot axios is a lumen opposing metal stent, so it should allow me to be fixed and not to migrate during my procedure. So those are the main reasons. Last but not least, it has a 20 millimeters diameter. That is one of the largest in the market, so that it fits very well for me.
Very good.
And again, is not long, so it's short, so it won't affect the small bowel. So I think it's one of the best solutions here. Hopefully, the best one to do what I'm going to do. So, second step, let's dilate a little bit. So I'm using a CRA, passing through the stent. Ok, vammi a 15. I will start with 15 in order to see. First of all, we are going to check endoscopically. Can you see radiologically the
Yes, we can
incisura?
see the balloon with the waist.
With the incisura, yes. But now I want to show you that incisura, okay, is not present anymore. Vai a 18. Let's go to 18.
Okay.
See that?
Yes.
See that radiologically is working very well?
Yes, yes.
Okay. Keep on going, keep on going.
Whenever we put a stent like this, sometimes we worry too much that it will migrate while we are doing the procedure, going in and out while it's still very fresh. What do you think?
I think that to be worried is always a good thing in order to keep your eyes open. It may happen, especially during this procedure or even during a long necrosectomy.
Yes.
Sgonfia. So we have described a technique in order to restore the situation. You can withdraw your hot axial stent outside the patient, and you can recharge the hot axial stent inside your operative channel in order to replace the situation.
That's very interesting.
Yes, I will give you the link for a nice case that we have publicated. First name is Alessandro Fugazza, our co-worker, in which he described this interesting technique that will allow you to get rid of some problem.
Very good.
So, hopefully, I won't have to show you in this live, but if the axis will migrate, I will show you. Hopefully, I will not.
Professor, there is a question from the floor from Professor Ashraf.
Please, Professor. Are you with me?
Can you hear us, sir?
Yeah.
Yeah, we have a question here.
Please, I understand that this is a gastrojejunostomy opening, so it should be an afferent direction and efferent direction. How can you direct your stent into the correct direction? Or you put this stent, how can you direct the stent?
This is another very interesting question that connects me to the previous one. This is why we use this kind of stent instead of tubular, because those are large and short stent. As you can see here endoscopically, we have just placed the stent, and now we have to decide to go in the afferent on the efferent. So you don't have to worry about the stent. You will decide when you go inside with the scope. And look at this. I'm going in, okay? I will check radiologically, look at that, and I will know that I have probably to go here. Let's see. Here. And probably we will find the papilla. Possiamo fare un Buscopan e preparare il catetere. Okay. So, can you see radiologically? I am nearby
the clips,
the biliary tract. I am going to do some Buscopan, but I think we are facing the area of the bilioenteric anastomosis.
The end of the anastomosis, yeah.
I will do some Buscopan. And let me check, in the meantime, where the anastomotic area is. We should see some air into the bile duct. I'm not seeing it, so this is something that I was supposing. Thank you. You see? You need to be patient here to understand where you have to go. And there it is. On the left side of your screen, you can see the anastomosis. See that?
Yes, we can see it, yes.
So sometimes, with a little time, being patient, and of course, with the help of Buscopan, you can find the place. So I think this is the anastomotic area. I will place a guide wire to see. Let's go. Radiologically, let's go. Okay. Yes. Okay. Very nice, Monique. Okay. Enough. Come back. Let's put some contrast. By contrast.
I think once you find the opening, this is the easiest cannulation ever. But needs that you find the opening.
Look at this. I can see some dilation. Okay, stop. I can see 3 bile ducts coming to the anastomosis. I can see some dilation. So I can tell you that this guy had some, manda sul filo guida, some problems of cholangitis. So, okay. Adesso sei molto su. So, what is in your mind just now?
Maybe inserting multiple stents?
I think this is the idea. But first of all, I'm going to dilate this area, lascia sul filo guida, with an hurricane balloon of 1 centimeter in order to allow me to place the stent later on. Fermo un attimo. Apri pure, preparate l'hurricane.
I can see a stone in the left duct. Am I right or not? There's a stone in the left duct.
This could be possible, or is just air. We need to check. But I think that placing stents, I see what you mean. Now I'm going to move the X-ray machine in order to understand better. I think that placing plastic stents would help also that stones that could be the effect of the cholestasis. But of course, now we have the biliary tract reachable, directly reachable with a scope you need, with the spyglass if you think could be a good idea. And you are basically free of doing what you think is better. So again, we do not have to adapt us to the situation. But by placing this lumen opposing metal stent, we basically are able now to work properly. Vai. Dai, dai. Ok, tieni il filo, tienilo fermo. So I'm going down with the hurricane. This is a plastic, you see, a balloon, okay, of 1 centimeters diameter. Let's go. We can see either radiologically. Ok, fermati. There is air, ok. Hai messo mezzo di contrasto? Sgonfia, sgonfia. I want to fill it with contrast first, ok? Sgonfia tutto, ancora. Ok, adesso rigonfia. Ok, let's see. Vai. Ok, ancora un po'. Stop. Let's go. Vai. Ok. See, radiologically, the hurricane is going. Vai ancora. Ok. Ok, quanto sei? No, vai. Quanto sei? Devi arrivare a 11. Okay, the hurricane is working. I want to show you also the through the balloon visualization of the anastomosis. Can you see endoscopically? Fermati.
Yes. Did you confirm the benign nature of the stenosis by biopsy?
Vai ancora. Sorry?
Did you confirm the benign nature of the stenosis?
Yes. We can assume that is, you know, an anastomotic stricture. So if you can see also by the through the balloon visualization, there is a fibrotic tissue. Can you see?
Yeah, we can see it.
And this is an answer to me because it helps you understanding better. Quanto siamo qua?
I have a question for the further management of this patient.
Ok, dai ancora un po'. Basta. Sgonfia. What's the question for me?
Yeah, okay, yeah, I have a question. Now we have placed a hot axios to perform the procedure through it. Of course, with the presence of the hot axios, now you can perform a very traditional scope and use whatever tools you want to do. You can place 1, 2, 3 stents, whatever you want to do. The plan is to repeat the same thing to reevaluate after 3 months. And of course, you will remove this hot axios stent maybe few days after the procedures to make sure that there are no complications after this procedure. Yes? Okay.
Well, the truth is that I'm going to leave this axios for at least 9 months because I want to treat this patient by multiple stenting. And so I am going to either change the stent or add some stents every 3 months.
Yeah.
Like we do transpapillary in other conditions.
Sir, I have a question here. Why you don't use enteroscope and with a long balloon, assisted balloon, and you do the same procedure without hot axios or without gastric connection?
Very interesting question. To be honest, for these patients, last year we started with the enteroscope in order to reach the area, but due to the long way, due to the angles, we didn't reach the anastomotic, the bilioenteric anastomotic. So we decided to switch to this other approach. But more important, I think that this approach is much better for the patient because it will allow you to work with operative scopes with larger diameter. So you are able now to use plastic stent, metallic stent, balloon extractor, Dormia basket, spyglass, whatever you need. So this is, dammi una 7-10, 8 French e mezzo, 7 centimetri. So this will allow me, moreover, to come back many times to this patient in an easy way. In expert hands, this kind of procedure is quite safe. And actually, we performed the procedure in a day hospital manner because during this period of COVID, we do not want to keep patients in the hospital unless it's strictly necessary. So the patient came to me in the morning, we did the procedure, we kept the patient until the afternoon, and then we sent the patient home. And the day after, by phone calls, we were keeping contact with him. But definitely, compared with the enteroscope, this procedure is much, much better in terms of outcome, technical and clinical.
Excellent answer and excellent explanation. Now, what about a metal stent for the biliary system?
That's another good idea. The problem here is that we have 3 branches of bile ducts that are connected very, very close to the anastomosis. So if I place a metal stent that should be covered, I'm going to probably close 2 of the 3 branches. So probably the best thing here is to place multiple stenting, either for this reason, tieni il filo guida per favore, but also because it has been shown that multiple plastic stents are able to modulate the stricture, and you can always come back either to place a larger stent or to add some stent. Now I'm going to place a plastic stent that is 8.5 French, 7 centimeters, in this first duct that to me is the most affected. Okay, stack il nero. So I'm using the Advanix, stack tira, that is going pretty well, as you can see radiologically. Tira un po', tira di più, di più, di più. Ferma. Ok. Ok. Vieni indietro. Do you see endoscopically? Vai.
Yes, we can see it.
So I just removed the black sheet inside. I am going to remove the guide wire, and you will see that the stent is now free. Then by the same introductor, I can try to do this trick to place again the guide wire. Let me check. And to try to adjust it and to go in another area, if I'm able. Otherwise, I will use the sphincterotomy, if I'm not able. You see, I am in the other duct just now.
Yes.
So I'm going to remove this.
Yes. They are asking here, what about a slightly longer stent?
Sorry?
They are asking here in the audience, what about a slightly longer stent to go inside the left branch?
Longer. This is a good idea. Actually, I thought this was long enough. So, but I think that this is due also to the patient, the position of the patient. If I'm going to change the position, you will see that is already dilated over there because the stent is after the first, let's say, angle.
Branch.
Yeah. So I'm pretty sure about that.
Very good.
But to be honest, I had the same question to myself. Ok, now I'm removing this. Devi aiutarmi, tira indietro e spingi il filo. Vai. Apritemi now un altro uguale. E allora un 10 French 7 centimetri ce l'hai? Quello. So I'm going to place now another 7 centimeters long plastic stand, but I want to place a bigger one. So a 10 French, because I had the feeling that we can go, I cannot say easily, but that we can go. And after this, we are going to try to place even a third one, if we are able.
Good.
So I'm very happy with this treatment, actually, because I think that the patient will benefit either for the cholangitis, but also for the remodeling, because we have dilated, and then we place 2 to 3 stents, and after 3 months, we can go back to see what's going on.
We share your happiness, and we are very happy that you shared this case with us.
You know, I'm happy because this is a 42 years old man that was working, has a family, 2 little child. So I'm happy because I hope he will find again the taste of life.
I feel from the history you gave that you are emotionally attached to him.
Tira. Okay. So now I'm pushing a 10 French stent. Grazie. Over the guide wire. This is the jag wire, actually. 4.5 meters, 0.035 inch. That gives me a lot of power, as you can see. The stent is going pretty well. Ok, stacca il nero. See? While Monique is withdrawing the black stuff, I am going to push and to see if I have enough. Ok. Ah, vieni indietro ancora di più. Nero. It's very important to check. Vai, vieni indietro, a bestia. Ok, vieni indietro ancora. Ok.
Very good.
Okay, so. See? So I'm pretty happy with this. Look at this. When you take it out, the guide wire, hop, he will go away. Okay, let me check with this other trick. It's not very nice to show you, but sometimes it helps me saving some time. So the guide wire now is going in another one. This could be good. So can you prepare another 7 centimeters, but 8 French and a half, because I think that we won't have enough space just now. Ferma lì. Ok, non mi piace. Dammi un... I'm going to take a sphincterotomy in order to angle. But if you can see just now the radiologic evaluation, I think we did a great job.
We think
Actually,
so.
I would like, while we are preparing the sphincterotomy, see, manico rosso, I would like to change the patient position and to place the patient on his back. Possiamo mettere la pancia in su? In order to check the anatomy better. Lo possiamo spostare, sì? So if you give me another 5 minutes, we are going to finish the procedure. And this is another very interesting thing to me. Look at the bile duct, how it's working pretty well with the plastic stent.
Yes, great.
If you suck, the bile is coming.
Uh-huh.
Ok? Puoi passare? Lo tengo io se no. Ok. Ok. Ok, sorry for this, but is 1, 2, 3. Let's go. Ce l'abbiamo fatta? Is to check better what we were saying. Ok, mettilo bene, bene. Ok. Ok. Hai messo già destro-sinistro radiologico? Ok. See that? Basically, you do not have any more. See radiologically?
Yes.
So I'm pretty happy with this. There is no
more
contrast anymore. So
Yes.
this allows me to tell you that we did good.
Yes.
Cosa mi hai messo sopra? Voilà. Okay, let's go. If we can go in another one to remodulate. So I took the sphincterotom with a hydrophilic wire. Let's go. Con la guida, per favore. Va. Vai. Va. No. Vieni indietro. Vai ora. I need to find. Okay. Okay, stop. As you can see, we are going in the same place. Butta contrasto adesso. We are going to place contrast and to see. Vai. Okay. Okay. So, look at this. I'm pretty happy. Ok, stop. Dammi il filo di taglio. Vieni indietro col filo guida. No, senza tagliare, solo filo di taglio. Vieni indietro col filo guida. Indietro, indietro col filo, indietro. Ancora, ancora, ancora. Ok, vai ora. That's good. Fermati, toglimi il filo di taglio. So, I'm going to try to find another way, if possible. Vieni indietro col filo. Vai avanti col filo. Contrasto. And you see that being patient, using the right stuff, we were able to reach also the third one. Okay, exchange. Let's place the jaguar. Okay. Intanto dammi contrasto un po'. Siamo usciti, siamo usciti. Ok, I've lost the position, rimettimelo. So I want to try to replace. No, aspetta io. Although I think that this is quite good, but in the next 5 minutes we take the time. Scorre, se non scorre, no, non sta scorrendo, vai. We need to take our time to try. Io non lo vedo scorrere. Dai. Ok, vai. Vai. Okay, vieni indietro. Vai ora. No. Sì, vai ora. No, vai ora. Ok. Tira indietro piano, vai avanti. Ok, adesso mettimi contrasto qua. Sì. Ok, 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 I like that, I like that. Adesso, ferma. Togli il filo. So, now I am in the other place. I'm going to place a longer wire. Here is not very dilated, but I want to keep safe also this area of the liver, because after placing 2 stents, we need to be able also to drain the other side. Da 8,5 cosa abbiamo? Oppure? Vai. Vai su, vai fino là, eh. Su. Da 8,5 abbiamo solo quella? Cazzo. Vai su. Sì, su, più su. Di più. Okay. Vai. Da 5 non abbiamo niente? Quella, va bene. Sì, vai su col filo guida. Ferma, Brava, così. So, I'm going to put a shorter one. In order to...
Is it better to use to put the 3 wires before deploying the stent, then deploy every stent after putting the 3 wires?
This is a good idea that I usually perform when I use the duodenoscope that has a 4.2 millimeter working channel. Here I'm working with the operative gastroscope that is 3.8 millimeter. So when you have such a diameter and you have a multiple guide wire inside, you may do not have the chance to place big stents. So that's why I choose this solution. But if I were with a duodenoscope, I would have done like you suggested. The problem is the diameter of the operative channel. So let's put this last plastic stent. The most important thing actually is to place the stent here at the level of the anastomotic area, that is the area where the stenosis is. Ok. Ci siamo? Dai. Ok. Sì, sì, vai. Ok, let's go. Dai una mano qua, Matteo. Dai, guarda che c'è incastrata qui. Dai, non farlo vedere però, per favore, e non tirare indietro il filo guida. Ok, fai così. Vai. Ok, stop. The guide wire is over there. Ok, tienimi la guide wire ferma. Più ferma. Ferma così. Ok, così va bene. Ok. Tira un po'. Tira. Ok, bravissimo. Bravissimo, guarda là in radiologia, finché sei là sei a posto. Ok, now I'm going to pass with the plastic stent, hopefully. Now will be much heavy. Also because there is an angle over there. I'm not so interested about passing the angle. You see, it's not allowing me to go. Tutto a posto, Ale, qua? Ok. 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 Sblocca il nero, non ti curare del filo, dammi tensione. Di più. Guarda in radiologia, eh? Più tensione, di più. Non deve andare così avanti. Guarda in radiologia. Tira più indietro. Brava. Ancora. Non ti preoccupare, manca tanto. Ferma. Adesso quando ti dico, tu tiri indietro. No, un po'. Vai, tira. No, un attimo non è nelle mie corde. Brava, tira. Ok, see the plastic stent?
Yeah, we can see it, yes.
Although it's quite
There is
large. Ferma adesso, ferma. It allows us to go and to do the bend. So I'm pretty happy with this. Tira piano piano indietro.
Yeah, perfect, yes.
Vai. Sì. So now we have what I call the Italian flower. As you can see in radiology. No, togliti però da lì per favore. Abbassati. Gioia. Dai. Okay.
Okay, so
can you see radiologically the
we can
situation?
see. Yeah, the three stents.
Endoscopically?
Yes, yes.
And now, before leaving you, look at this, endoscopically.
Yeah, we can see the three.
Okay, so from the biliary tract, we are happy. Now we need to see if the axios is still there.
It's still present, yes.
Because I know that all of you, Garzina, are waiting for this situation.
We enjoyed seeing your hands working in the very nice way. We are again thank you for sharing this case with us, and we hope in the future we'll see you in person. And
Yeah.
now we are going to leave you because we are going to a presentation.
That's good. I want to thank you for giving me the opportunity to enjoy with you. This is the last picture of the axial stent that is still in place.
And we hope to see it again after the 3 months.
Yeah, we can organize something similar. So
Yeah.
I will be very happy. Looking for this.
Thank
you very much.
Thank
Stay
you.
safe.
Yeah, yeah.
Yeah,
Stay safe.
it's a wonderful job.
Hello
Excellent
from
job.
Milan.
Thank you very much. So we have to move on to a presentation by Mr. Hausmann Volker. He is the senior product manager in Boston Scientific. He is going to present the probe that we were supposed to see now. Mr. Volker, Mr. Volker, are you with us?
Absolutely. Good morning to Cairo. Hello from Bonn, Germany. Nice to meet you all there. Just try to share my screen.
Allora,
Can you,
tu mi chiami, mi dici quando si sveglia il paziente?
can you please share the screen or give my presentation free?
Can we have Mr. Volker here with us here?
Yes, I'm with you.
Yeah, okay. So we're still can't see the image.
Okay.
Yeah.
Can you see my
Yeah, we can see it. Yes, yes, yes. Now we
Perfect. Perfect.
Okay.
Thank you to the audience. Thank you for the invitation. Allow me to give you an introduction about the Habib RFA probe. Just starting my presentation in a second, and please let me know if you can see it. Yes.
Yes, we can see it clearly. Just make it full screen, and we will be happy to follow your presentation.
Full screen.
Okay.
Yeah, perfect. Yes, we can follow you. Okay, go ahead.
Perfect. Thank you again for being in this nice endoscopy live session. And I just want to talk with you about the Habib Endo HPV bipolar radiofrequency catheter. And it is named by Professor Nagi Habib. He's an Egyptian physician, by the way, now working in the Imperial College in London. And he founded a company called EMCision that has developed this kind of probe. So this is a product developed from physicians to physicians, basically. But nowadays, it's more than 13,500 procedures done with this probe. We have a lot of peer-reviewed papers, and it has last year been rewarded by the Edison Gold Awards for innovative medical technology. I just give you a quick idea how this catheter works. It's basically two stainless electrodes, 8 millimeters long, 8 millimeters apart, on an 8 French catheter. And this is basically connected to any kind of electrosurgical generator. You do not need to have a specific dedicated hardware for that. Simple placement, really put your catheter over guide wire to any kind of endobiliary stricture like that. You place the electrode in the middle of this. And what we're doing right now is basically a slow cooking. We're just simply heating it up just by 10 watts, not more, for 90 seconds and allowing it kind of cool down. This allows immediately application of an ablation of 25 millimeters in length and roughly 1 centimeter in diameter, meaning you have immediately gaining additional diameters. You can also use this kind of catheter for cleaning occluded metal stent. Similar procedure, 10 watts for 90 seconds, and then it's cooled down. It's really a very simple procedure. You have not a big learning curve here. It's really easy to use this stent. So with this said, I'm moving over to what's going inside, because you normally can't see what's going inside the bile duct. So it's ablation starts at the electrodes, and then it fills the gap in between the two electrodes until you have every time a very consistent cylindrical shape of 2.5 centimeter and 1 centimeter in diameter. And this is really performed and defined by the anatomy of the electrodes. So you can be sure once you have done this ablation, you ever have the same kind of ablation, and you will also not miss any kind of maybe nearby vessels. So this is an example of a kind of liver tissue where you can see it's really consistent whatever tissue you have. Where are you going to use this product possibly? So I have mentioned several disease states here. First of all, we're talking about cholangiocarcinoma stricture management. So this probe allows you really proactively manage patients with radiofrequency to prolong patency of a stent. So we have really some very good data. There's a study from Young showing that the patency improvement is really doubling when you're using plastic stents from 3.4 months to 6.8 months. And if you're using this RFA probe to use and to clean metal stent, you have an increased patency from at least 1 month. And it's really safe to use. It shows, the data show there's no significant difference between using RFA and stenting alone. The only thing that patients may feel a little bit pain in the stomach, which you just improve over one night with some analgesia. A second very nice indication for the Habib probe is basically the treatment options following papillectomy, when there's residual tissue left over. So you will see that there have as well are no major adverse events, and you have a residual neoplasia at 6 months and 12 months of only 15 to 30%. If you imagine that with this procedure you are saving the patient possibly a Whipple procedure or a larger procedure, I think this is really a good use of radiofrequency ablation in the bile duct. As well, if you're looking at pancreatic cancer stricture management, you know 75% of the pancreatic cancer is happening in the head of the pancreas. So if this is compressing the bile duct, although it's possible to use the Habib RFA probe, so you have a patency improvement here as well, and you also increasing in this case from in this paper that is mentioned from 374 days to 472, almost 100 days. So you can really improve patency for those stents in this patient cohort. And as well in benign indication, you need to know that this probe has a benign indication as well, and can be used in malignant and benign tissue prior to stent placement or afterwards. So I'm thinking about PSC, I'm thinking about IPMN. Those are typical cases where you can use the probe as well to treat the scar tissue or to get rid of the IPMNs. What is really interesting to understand is how do I use when I have a cholangiocarcinoma patient. And I'm proposing here an algorithm that has been discussed and promoted by Dr. Jeff Islam, one of the leading physicians in the US who was really some very long experience with RFA probes. And it looks very complicated, but at the end, it's really simple. So first of all, you need to decide, is this patient resectable? Sure. If the patient is resectable, please send him to surgery. That's the best way for him. If he is non-resectable or maybe borderline resectable, just check the functional status of this patient. Can you drain the patient, and where is the cholangiocarcinoma located? If you have a distal cholangiocarcinoma or Bismuth 1. It's very simple. Use RFA and place a metal stent. You have this improved patency. And if this stent at some point has an overgrown or ingrown, repeat the same procedure, and you keep this patient out of hospital for a long time. If the patient has a perihilar cholangiocarcinoma and has a poor functional status, a very short life expectancy, and you know you can't really drain more than 2 liver segments or less than 2 segments, then again, keep this patient out of the hospital in a good condition, again, do RFA and place a metal stent. Most of the time we will see such patients who have a good functional status. You can drain more than 2 liver segments and you're looking for adequate decompressions. In that case, you may use RFA and plastic stents. And you're going to repeat this after a while. After more than 8 weeks, you order this patient back into hospital until at some point this patient deteriorates and is going to die. We know that we are talking about the palliative situation and not a curative situation. And a good friend of mine, Dr. Tobias Weissmüller from the University Hospital Bonn, has reported about a case where he has repeated this up to 5 years. So if he led a patient 5 years through this algorithm, RFA, plastic stent, repeating after about 10 to 12 weeks and continues with this. And this patient, as I said, has really survived for more than 5 years. So that's basically the strategy how to plan your patient treatment algorithm with RFA in diagnosed cholangiocarcinoma. You may ask what our clinical experience do we have, and I have mentioned here some of those papers. So basically we have an improved patency rate in metallic biliary stents. We have seen that when we clean up an occluded metal stent, you have a really high patency rate compared to plastic stents in stent. In plastic stenting alone, we doubled with this RFA, the patency, and it's a really nice opportunity, an option to restore biliary drainage. And you need to know it's really a safe and effective treatment option. And there's no significant difference in the risk of cholangitis, cholecystitis, pancreatitis, or kind of bleedings. That's what the clinical paper says so far. And here you see some pictures you may recognize on the left side, a pre-radiofrequency cholangioscopic image with cholangiocarcinoma done with a SPY scope. And immediately after RFA, you see the tissue has been whitened. There's no blood vessel anymore. You have completely ablated this tumor, and you can see the opening to the liver segment here. That means immediately after post-RFA, you have an increased diameter of the duct of approximately 3 to 4 millimeters. And on the right, you see such a treated bile duct after 6 weeks. It looks really nice. It looks really like a native bile duct, and that's what you can expect. I'm showing you these pictures basically because with a normal fluoroscopy, you will not see that. But this is, and thanks to Dr. Gunnar Singer, who has provided us with this data and his pictures. I think this is a good demonstration how it looks over the time and why there is an improved patency, because you really have this good local tumor ablation. With this, I am just finishing this presentation here. Do you have questions so far? Otherwise, I can share some videos that gives you some simple 3 cases recorded from Dr. Weissmüller. I cannot hear right now.
Did you finish?
Yes, yes. I'm open to get your questions, please.
Yes, okay. Could I ask a question? I'm asking about this probe. Does it fit any generator?
You can connect that to any kind of existing generator in your OR suite. It comes with a cord, a reusable cord that can connect it to any kind of generator. It's very simple settings, 10 watts, and it's just like placing a catheter above the structure.
Okay, is it single use or reusable?
This is in a bipolar electrical probe, and it's a single one because you never know once the isolation would fail and causes a kind of electrical damage inside the body of a patient. So that's why it's a single one.
Do you use this probe through the spyglass or through the scope?
You can use this. It's an 8 French catheter, so it fits through a duodenoscope, but not through a spy scope.
How can you control the depth of the ablation while you cannot see during the procedure? How can you control the depth?
Yeah, that is exactly a good question. So we know by the geometry of this 8mm electrodes, 8mm space in between plus 8mm adds up to 24 millimeters. We know exactly that this algorithm, this ablation algorithm of 90 seconds, 90 seconds ablation by 10 watts is really creating this 2.5 centimeter ablation zone by 1 centimeter. So it's consistent. You have on the most of the electrosurgical generators from the Elbe company, you have this smart meter showing you that energy is applied, and you are absolutely under control of that. Once you put a pedal for 90 seconds, you can absolutely trust this more than 13,500 procedures done, that this is the outcome.
Any questions from the audience? Any questions? Okay, now we are ready for your video.
Okay, perfect. Let me switch over then. We did a nice training last year with Dr. Weissmuller from the University Hospital in Bonn. And he prepared 3 cases from his experience, and I want to share my screen, but it doesn't work right now. Someone needs to give me access. The host disabled participant screen sharing. So I'm the host now. It seems it can work on that. Perfect. So I'm just giving you those examples. It's a recorded session here, so I'm not sure if you can hear the sound of Dr. Weissmuller.
It's not clear.
You can hear?
The sound is not clear.
The sound is not there. Okay, how can I put on the sound? Can someone from help me out here? How can I put on the sound? Sound is on here. Now I'm playing it again.
I think you must choose from the allow the sound from your computer.
Okay, let me just quickly mute. Same as system. Leave computer audio. Switch your phone test. Leave computer audio.
No, we can't hear you. You have to allow the sound of the computer. It is. I think something has to be done from the 3 dots on the right side, lower right side.
With computer audio, can you hear me now?
Yeah, we can hear you, but we cannot hear the sound of the video. Because you need to share the sound of the computer.
That's what I try to do, but it seems I have the option select the microphone same as the system. Maybe it's
this will allow your voice to come out, but we have to choose from the 3 dots on the right side. The 3 dots on the right side. No. Exit the share screen now.
Here. Is it this one? Share sound.
Exit the share screen. Exit the share screen.
Okay.
Yeah.
New share. Yes. Got it. Here it is. Perfect. Found it. Thank you so much. Thanks for your help.
Yeah, you're welcome.
And phase 3 is a patient with residual papillary adenoma after papillary.
Okay.
So this was a patient I remember very well, a 73-year-old male in a quite good clinical status, but unfortunately we had the diagnosis of a bismuth 4 extrahepatic cholangiocarcinoma in April 2013. And we started to treat him, as I told you before, with chemotherapy systemic and with RFA every 3 to 4 months. So when you start those patients to treat, Volker showed you how to do it. It's very easy. You just have to put in the probe like you do with a stent. When you have a hilar tumor, of course, you treat both sides, and you have a zone where there's a quite of overlapping, but that's no problem of the probe. Then we repeat the RFA after 3 months. And you see very nicely then when you have treated the patient sometimes that you have a very good response in the bile duct. There is no stricture anymore. It stays quite open. But also you will recognize when you do RFA that immediately afterwards the tissue is swelling a little bit. So it's important to do stenting between the RFAs. And for 2 years, we had a stable disease. You see here the nicely opened hilum of this patient. And only 3 years after the diagnosis, there was a mild progress, and you see that the tumor now grows more into the liver. That's what we see after some time of RFA, that after years, of course, the tumor progresses. But we had stable disease for 3 years in this patient. We keep on treating this with RFA, so we put the probe here and a little bit down below
You can see
to keep
easily the electrodes.
the
right?
bile ducts open. And this is how it looked in April 2017, and this in June. So there starts now a progression with stenosis of the left hepatic duct. But for many months here until December 2017, we could keep the patient in a good clinical condition with aggressive use of the RFA ablation. This changed after 5 years of therapy, when we first saw in this patient an arterial intrabiliary bleeding 4 weeks after his last RFA. This bleeding could be controlled. It was due to a pseudoaneurysm of the right hepatic artery, and the tumor had, there was an erosion from the tumor of this pseudoaneurysm. This could be controlled by embolization and by biliary stents. However, after this, we stopped to perform RFA in this patient. 5 years after the diagnosis of cholangiocarcinoma and following 14 cycles of chemotherapy and 20 RFA sessions, our patients died because of liver failure, of peritoneal carcinosis with ascites, and of encephalopathy. Here you see survival course of unresectable cholangiocarcinoma, and you see no patient in this study without treatment survived more than 2 years. So I think 5 years is a very good result for this patient, and I can tell you that he had a very good quality of life just 2 months before he died, due to consequent treatment of his hilar stricture. The second case I want to show you as a more rare situation, an IPMN of the bile ducts. This was an old lady, more than 80 years old, with many comorbidities, including an inoperable breast cancer. And the patient presented to our unit with cholestasis cholangitis, and you see this interesting picture here with multiple cystic lesions of the bile duct. When you took a balloon and threw it through the bile duct, there came out a lot of mucus and of slimy tissue. And we also performed cholangioscopy, and you see here this mucus, and you also see the villus tissue at the growing into the bile ducts, like here, for example, also with very abnormal vessels. We took biopsies, and the pathologic results were that the patient had an intraductal papillary biliary neoplasia with low-grade dysplasia. So no cancer, but of course we know that in IPNB, this disease progresses to cancer. Normally you would send the patient to a surgeon, but this patient was not operable due to her comorbidities. So we decided to perform RFA. And you also see very nicely here that when you compare the picture I showed you before, that after RFA, you can keep the extrahepatic bile ducts open, and you kind of clean the bile ducts from this tumor tissue with the use of RFA. So we also treated this patient for many times every 3 to 4 months with stent exchanges between. So this is, for example, after her 5th RFA, and you see that the extrahepatic bile ducts are very good opened after this treatment, and there was no catastasis anymore for a long time. Our patients finally died 4 years after diagnosis of IPMB, not because of cholangitis or because of the biliary tumor, but due to multimorbidity, dehydration, and cardiac decompensation.
So these are 2 cases, and I just got a signal that we need to stop due to time results.
We have prayer break now. So thank you very much for this amazing presentation and the video. Before closing the session, I'd like to thank Professor Dr. Ali Farag and Dr. Muhammad Naguib. I'm extremely proud to be sitting in the same row with such great eminent professors. I'd like also to thank the one who gave all of us a lot of opportunities to be here and still doing till now. Not our boss only, but our spirit and our backbone. Professor Dr. Hazem Hakim, the workshop chairman. Thanks, Dr. Hazem. Thanks for attendance, and we will be back after the prayer break. Thank you.
Thank you so much. Bye.